we've all been able to grab a glass of water or a cup of tea, and we're ready for the next 1.5 hours. My name is Dr. Rhoda Kalondu. I work at Kenyatta National Hospital as head of Patient Safety Unit, and I'm excited to invite you to this webinar today where we're focusing on patient safety. It's a patient safety series that will be running in the course of November, culminating into our conference that Dr. Lydia Okutoi will tell us more about. Our topic of the day is aligning hospital quality and patient safety programs, and we have Dr. Lydia Okutoi, Mr. Thomas Kashuki from the Ministry of Health, and Dr. Olga Nyamor from Kenyatta University Training and Teaching Referral Hospital, KUTTRH, who will be sharing their experiences on matters aligning programs or bringing programs into the institution. We are proud to have these three panelists, one who's experienced in introducing programs in a referral facility, that is Dr. Lydia Okutoi, Mr. Thomas Kashukia, who's in charge of policy and is really conversant about policy making and rolling out and implementing policy. And we have Dr. Olga Nyamor, who's currently instituting quality programs at KUTTRH. So she's just starting, and we're excited to learn from her and also see what we can borrow from her experience and what she's learned so far, and what are some of the things from somebody who's just starting, somebody who's already created programs, what we can learn and pick from this. So Dr. Lydia Okutoi, karibu sana. Maybe you could start us off with your presentation and just do a brief introduction of who you are, and yeah, tell us something about yourself as you start.
Thank you very much. Good evening, colleagues. I just put on my screen to say hello so that munione the face. When we meet on the streets, we can say hi. Great. My name is Dr. Lydia Okutoi. I am here representing three teams, but the one that brings us to the highlight is a Society for Quality Healthcare Kenya, which is a multi-professional society for healthcare workers interested in improving quality of care where they are. It also invites other interested parties, including patient advocacy groups, just for their voice to be heard, because patients are important and care has to be patient-centered, responsive to their needs. So we also encourage advocacy groups, if they're interested, to join. So we have from nurses to physiotherapists to radiologists, pharmacists. Our aim is to invite all so that together we can make the customer journey, the journey of the patient. Yeah, the patients actually told us they prefer to be called patients. They are not clients or customers. So that their journey during care to be of value addition. I work at Kenyatta National Hospital. I appreciate my employer. They have enabled us to be part of this journey at facility level and supporting also the country. So a lot of insight that I'll be sharing, I may have a bias from what we've been able to do at the hospital, and we support the Ministry of Health. That is where Dr. Thomas works in their technical working groups and other quality-related teams, including the drafting of the Quality of Care Bill. So Society of SQHK has been part of that journey, and we are glad. So we are going to have our first scientific conference on the 28th of November. It is a Friday, it is a whole-day conference, and so somebody later will share a poster. We truly invite you to mark this milestone with us. And so thinking about what topic or what we could look at as we get to this conference as our theme. Our theme is start where you are, build with what you have, quality and safe care for all. Because when we think about having organizational structures or departments or units or committees that support quality and safety, it looks like a big thing. Somebody can look at Kenyatta and say it has a division that is doing all this. Where do we start? And so that is what made us take that as our theme our aim is to be granular, that we will not be talking big things, but we will enable the participants of the conference to be able to envision what this can be in their facility, discussions and co-creation on how do we have accountability, how do we have sustainability, how do we have inclusion when having these programs in the hospital, and what does growth look like, what could be the challenges, and what would we want the MOH to hear with regard to this topic, because it's also very important to them, because they are rolling out policies that guide on these matters of governance, alignment, and ensuring there is value for every other staff or department, and just to create enablement. So I think as an introduction, that is why we are here. And so aligning hospital quality and patient safety programs is what you have been doing in case you're in this field, but we just want to put our thoughts together on what has worked and what can we borrow from other countries, other levels, and what can we adapt to make it fit. Great, so that is Lydia. I'm a clinician by background. I'm a gynecologist. And so I come here with a clinical perspective, but now supporting operations at KNH. And so we look at objectives and the rationale, and then we'll have some reflection at national level, and what are the governance and coordination mechanisms, and how does the facility level look like? How can we have these programs have alignment with what the rest of the hospital is doing, and what can we learn from KNH? So that will be the outline, and I'll invite my colleagues to share something about the policy level. That is Thomas, because he's currently working on that actively. And then also we will have our Dr. Olga from KUTRH. Great, so I've already alluded to the objective. And then we'll also look at the highlights of a successful programs. What are the hallmarks of a successful program? Great, so why should you have this as something that is essential? It's because we desire that care that is delivered in our facility is safe and is of high quality. We are aware that safety is a component of quality, but we separate it because it needs some form of affirmative action and commitment. So we talk of safety and quality. Then the activities that happen at the bedside where the patient is should align to the organizational ethos. When we say that we provide that safety is our value, then those frontline activities are the ones that will testify to the customer, to the patient, that indeed safety is our value, that we are interested in improving, how we will listen to their feedback. So rubber meets the road at the front line, but it should align with what we say we stand for as an organization. And also we do this because it enables us to look for outlier outcomes, to surveil for any behavior that is different or any outcomes that are different. It helps us to be proactive and have preventive activities. And it also enables us to know where to emphasize on in terms of building capacity for the healthcare worker. And this also builds capacity, both for the people, but also for the institution, because as an organization, you become one that does reflection. You reflect on where you are and you grow the capabilities to ensure that care will be safe and that it will be given care that works. So when we have these programs, they bring these big words to actions and activities. And the patients who come there experience it. The staff who come there get into that culture that encourages that correct behavior. And another part of the rationale is the wider clinical governance, that it creates an enabling environment where quality can thrive. Clinical governance is defined as a system through which organizations are accountable for monitoring and continually improving the quality of services and safeguard the highest standards. That is from NHS. And the essence is down there, that so that we may have excellence in the clinical care, that we will flourish in what happens right, does not just happen one-off, but continues to happen. We can see it when it is happening. And when it is not happening, we will identify it because we are monitoring. And so the essence of having the programs is that they enable now clinical governance to happen, that we are accountable to deliver that care to the patient. Also, another important thing of the programs is that they enable us to have system-wide learning. It is possible that one thing could happen like in a large facility on zone X or at accident and emergency, and another similar item is happening or an issue that is not maybe as good in a different place. And it's also possible that something very good could be happening at a different location, yet the other location is not aware. So when we have these programs, they enable us to know how we are performing for the purpose of benchmarking, even across the institution. We will say we have an island of excellence with regard to, for example, use of the family conference tool. We say that a certain critical care unit has adapted them. They are using the family conference tool. And so as a system, we can learn. Then also the various components of the system, that at one point we can say we have to address engineering, or we have to address maybe our communication, so that as a system, all the people involved, what is happening in nursing with regard to this thing. So the aspect of learning health systems is the capacity to reflect on your performance. And so these two are big words, clinical governance and having a learning health system with system-wide improvement, are what enables the rationale for why we should have this program. This is a slide that have been borrowed from documents from Thomas, that we have the national policy that's for patient safety and healthcare work and quality of care. So this policy clearly defines that there should be governance mechanisms that enables coordination of the activities around quality of care and patient safety in the hospital. And so there is the what we call why we exist, your mission, vision. It is all usually very flowery, world-class, patient-centered. And so, but what that means comes to be explained or comes to be interpreted in activities that the policies have clearly alluded to. And this is coming from a global document. There's one called Towards Eliminating Avoidable Harm, and then there's another one for the National Quality Policy from WHO. And they all allude to the fact that it is important to have governance mechanisms at national level, subnational level, to facility level, and even how do we involve the very patient. And so this is not a new concept. This is from the Kenyan document on matters quality and safety. We have what is happening at national level. There is an advisory committee, and then there are other teams. I think Thomas will allude to this. There are technical working groups, there are focal persons teams, and then there are also partners that are included in these groups. And then there is what is happening at the level of the sub-county. Thomas will talk more about the governance structure at national level, but I will concentrate at facility level. So we're just saying that what is happening at facility is a replica of what is happening at national level. And so national level is towards policy development, while when you come to facility level, there are advisory committees that enable the facilities now to function. Some facilities adapt the national policies, or they also developed other policies using best practices to do with the other subjects, matters that they may be interested in. For example, in KNH, you may not have a health worker safety policy as such, but that is alluded in the HR document. So when you come to patient safety, when we talk about the health worker safety, we're talking about that which is related to IPC and such aspects. So we may not have such a policy, but we depend on on the national policy with regard to that, but the other documents within the institution still allude to patient safety, healthcare worker safety, and quality of care. And so this is just at national level. I will allow Thomas to mention something about what is happening at the level of the national later when I finish my slides. So why is this important? It's important also because the policies are important because they guide us even when there is a changing landscape. Like we have the quality of care bill that is somewhere on a shelf. So that itself will define how quality and patient safety programs are run in the institution. They will guide the objectives and what should be mandatory, what should be measurable. And so the roles of this document, including one that I've pasted here, the one for the quality of care certification framework for Kenya, which talks about accreditations and the various levels. So that just guides what does safety look like in terms of what is mandatory and what will be measured and what will be monitored and what should institutions have. And so the roles are to have this landscape change be still guided at all levels. What are some of the aspects or the structures that enable us at national level and subnational level to do what is right? Like what are some of what we call the success factors? The success factors will come from specifying who leads this and what are their roles and functions and who is their support. For example, at national level, it is clear who will be the chair of the technical working group or who will be the leader of the various teams, the focal person teams. Because when the leader is specified, then the aspects of quality of care and patient safety, the activities will be embedded in their roles and how successful those teams will be. And so in Kenya, we have the other policies, including the IPC policies, AMR, and many other policies. But when you specify for a role that is cross-cutting, like quality of care, when the leader is not specified, then it is difficult for it to be successful. And when the terms which will give us the activities, when they're not specified, then it is a challenge for you to know whether you're doing what you're supposed to. And the terms should include up to who this reports to and how often. The secretariat are the foot soldiers. And so whenever the team membership has been specified that the leader will work with these people, but the secretariat is not specified, then the foot soldiers may not be clear. And so this reflects also at the national level, at the facility level, because this is what I'm mentioning about specification of leaders and the terms of reference and secretariat. This is what is defined in our documents for the national level. Allow me now to come to my task, which is the facility. So the Global Patient Safety Action Plan has 7x5 matrix, which tells us what objectives we should have. And the 1 and 2 allude to governance, policies, and reliability. And so they enable us to know what programs or what teams should be there. And in this, there's guidance for what the national level should have, but then also facility and up to patient groups. And so what I've copied, what I've put here is from the facility level. And so I've just picked a few from 1.1 and 2.1, some up to 1.5 and 2.5. So I've just picked a few things that are relevant. They talk of a dedicated team to address quality and safety at the facility level. They've talked of commitment of the facility to quality and safety because the facility will either have a vision or mission and they adhere to it. They've talked about culture, policies and guidelines, and that performance of the institution also looks at performance on matters quality and safety. So it is important that we track performance measures on quality and safety, and that there is enabling environment, including finances and otherwise, to implement the quality and safety programs. Then there is staffing and capacity building. Then also the regulatory and mandatory items that are supposed to be done on matters quality and safety to be adhered to by the facility. Of course, some of them are licensure, some of them are accreditation, or some of them are certification. So in whichever level the facility is guided to adapt this framework, which is a WHO framework for the Global Patient Safety Action Plan, to the facility. And so this is the guidance for the facility, and the Kenyan document has heavily copied from it. So copying from the Royal College, I think this is an NHS document. They talk of the 6 main items that these programs should touch. The leaders for quality and safety should be able to touch aspects of the engaging the patients, engaging the staff for improving safety, aspects of risk and risk mitigation, and then they should determine the common causes of harm. For example, if it is in theater, what are the common causes of harm? And endeavor to reduce them, meaning they monitor them. Determine what are the common causes of harm and monitor them. And then also use of ICT for patient safety. Is there a way we can have decision support, intelligence that is provided by the kind of information that we have? And are we able to report harm, incident reporting? So with the ICT system and how we use it, and how we also use other channels of incident reporting. The number 6 is leadership and governance. So this is a document from NHS. Also another, this I think is from the US on the essence of quality of care leadership, whereas the nursing leader reports to the chief nurse or the junior nurse in that hierarchy. The MO reports to the consultant, and to that hierarchy to the head of department. The healthcare quality leadership should be non-hierarchical. There should be an opportunity for anybody across the system to come and discuss, let's say, harm that has happened in an institution with this dedicated team. And this example here is for, I think, a Harvard medical-related Brigham Women Hospital in the US, where they have a chief quality officer, and reporting the chief quality officer, there's a quality head, safety head, documentation, and risk management. And then there is a chief medical officer who supports the IPC. And then there is chief nursing officer supporting patient relations. And then there is VP for strategy that supports data and analysis. So all these are the ones related to quality and safety. So what they're trying to say, whereas they have these dockets, if somebody from obstetrics and gynae who reports to the clinical director has an issue, they can come to any that is relevant. So quality and safety reporting should be non-hierarchical so that it's able to serve its purposes. Not that it doesn't have a reporting line, but there's a horizontal relationship that we can break hierarchy for the purpose of talking about quality, opportunity to improve, or to reduce harm. Then this should enable care. And then also there's an important role for the nursing team, because the nursing team are present at the bedside longer than the rest of the team. So the role of nursing in quality of care and nursing leadership, so they have to be enablers, and whichever organogram is used, the nursing team has to know that it is part of the center, and then integrating all staff, not thinking that IPC is a nursing aspect. The IPC is for all, for the surgeons, for the orthopedics, for the physiotherapists, and for the plaster technician. They have to wash their hands, they have to adhere to the IPC protocol. And so when having this relationship, we have to determine the source of data and the effort of data that will be required. That's why we have data and analysis as part working in that team. And so the kind of data that will inform change. So there has to be a good relationship between the ICT and the quality of care and the leadership for the purpose of picking the data that can inform performance. So coming to KNH, we have the CEO and then the Director Healthcare Quality, who reports to the CEO, but with a strong line to the Senior Director Clinical Services. While we have the Senior Director Clinical Service, Corporation Services, who has the Director Planning and Strategy reporting to him, but there is the quality assurance on that side. So there are two. There is both the administrative side and the clinical side that supports the important matter of quality. But the Director Healthcare Quality Office, where I serve, there are 5 units that report here that are involved in quality and safety. There is a patient safety unit, which I've put in orange. Then there is the IPC unit, which is also a patient safety-like unit. Then we have standards and process improvement, public health, and patient affairs that addresses patient-centeredness. And so the roles have been clarified, the hospital instruments that help this, and reporting lines that are clear in terms of at the level of reporting to the board. Then through the Senior Director Clinical Services, a board report is given to the board subcommittee, and we are able to share what is happening at that level. So also on building capacity in terms of technique, expertise, patient safety and quality of care is a science, and it is a science and an art, and it requires schooling of some kind. And so there has to be capability built in this team, but also across the hospital. And their performance has to be monitored, appraisals, all with regard to the mandate, because their roles are specified. KNH has an organizational structure and grading that includes patient safety. So there is patient safety officers, and we also have the patient affairs. I've just given an example. We also have the QA, the quality assurance that supports ISO and the quality programs that are to do with certifications. And so it is not like an island. There is a career trajectory or growth, career guidelines with regard to these roles. And this is just the case for KNH. And so that team cannot be able to do all that concerns quality and safety because it happens at the bedside. And so all the staff, all the departments. And so there is a role for the departments to be involved in this. On accountability matters, I've mentioned performance contracting, target setting, media review, peer appraisals at departments. And so this will happen to this dedicated team on quality and safety, but it will also happen across the departments. So across the departments, like for the pediatrics, obstetrics, they all have targets and performance contracting targets that are related to quality and safety. And even their quality objectives, all of them have quality objectives to do with their core mandate. And in there, we put patient-centeredness, we put IPC. In there, we put patient safety matters. And so there are departmental committees, unit committees, but there are others that are cross-cutting: morbidity and mortality, medical advisory committee. And as I mentioned, healthcare quality gives a board report every quarter to the Clinical Governance Standards and Research and Ethics Committee. Another opportunity of reflection on the standing committees include the Medical and Therapeutics Committee. It is a safety committee. It is not called patient safety. It is the secretariat is a pharmacy. But by and large, what happens in medication is a key area in any hospital. Then we have a patient safety committee that enables us to run and to think about our documents and to review the things that we have, including the incident reporting. There is a patient-centered care committee. So these are just some of the examples to say that you have a dedicated team, but that is not enough. The whole hospital, all the departments have to be involved in one way or another to have their formularies, to have their tools, to have the consent and all the items that are needed. But there are some few items that will be taken by this independent committee, or rather the dedicated team with their committees. They will look at How are we using family conferencing tool across the hospital? How can we review the patient charter? How can we review the consent form? How our treatment sheets that will be done by the MTC committee? What protocols need to be revised? So the quality assurance team will help with the system-wide review of everybody to do their thing. But when it comes to something that is specific, that cuts across departments, then they will look for this dedicated team. They will look for this committee. Can you address this item? And so we need to have both of them. These are examples of some of the things that are being monitored across the department. Every department will do customer satisfaction surveys. Every department will have their mobility and mortality reviews. They will have their hospital-associated infection surveillance. They will have their turnaround time, a discharge process. But there are times that these items will be taken to this dedicated team of healthcare quality. For example, what do? We monitor the medical errors, the reportable events, the clinical, the ethical dilemmas in care. So we track and monitor that, we respond to them, but then also we find what are the underlying causes, what can we do to reduce, how do we support the patients better. We also were addressing consultation forms across the hospital, the discharge processes, the customer journey mapping. This will be done by a dedicated team. So the essence of this slide is to help us know that there is the role for the quality of care programs across the whole institution. It is all our mandate, but there is also a role for a dedicated team to carry on some aspects. An example, that the patient charter and the customer feedback that we do both across departments, but then also those done by patient affairs as a dedicated team addressing some specific clinical complaints. Great. So there is also an example of having escalation. Escalation was a challenge, and so we were asked to develop an escalation protocol and gave it to the quality assurance team to run with it. And so those are some of the system-wide support that we are able to do. There is another tool here for admission and discharge requirements. We made an attempt, but right now it's being done by the finance team. Great. So how do we have this organization that is conscious, that is safety conscious, or that how do we up our appetite for ensuring that our work processes are safer? At an organizational level is to make safety a priority and have all staffs involved and be responsive to what the patients are bringing before us or to what we are seeing, and to allocate resources. If there are resources for a certain product or a certain process, we will be part of giving the voice, because remember, this dedicated team will not be everywhere, but they'll be part of saying, yes, for sure, this is required in pediatrics, because we are seeing it through the patient safety lens. Then also addressing the employees and ensuring that they're able to have the capability to support improvement. Healthcare quality has been training 50 staff or so every year in at least a 5 or 3 days training, which enables empowering them to be able to be part of the doing at the front line. Great. So as I come to a close, what can we consider? We can consider on matters quality and safety programs what are our commitments? What does the regulator want us to do as mandatory? And what are the things that we can do at facility levels? They are not mandatory, but they are good to have. And so are we tracking those commitments, both the ones for the regulator and the ones that are around quality, safety, and patient-centeredness? Then also we consider our organizational performance and what are we contracting for? What are we appraising for? Then what is the size of our institution? And so when we have a dedicated team, will it make it as too thin, or will it be redundant, or do we just need a committee? And how do we enable that committee? How do we build that capacity? Also, another thing to consider is the use of institutional data and what effort we can put to have this data be collected on a regular basis. And so these are some of the thinking that the dedicated team can come and think with the frontline, but the frontline will continue having it. If it is digitized, then it will be less effort for collecting data around quality and safety metrics. And that will depend on also the capacity of your staff and the number that they are. It's important to onboard the board of management, senior leadership, middle management, even up to the newest who are joining the institution, onboarding of the new staff, of the registrars, of the visitors. Yeah, if they're coming to stay for maybe observership. So how do you onboard them? So building the institutional capacity to be able to identify the opportunity, to build capacity both either externally, but more so internally, and having a culture that is open to learn, and a culture that enables us to have champions across the institution, so that the quality is not a team, but quality is us, and the champions are the ones who raise the flag that come here, there is a need. Come here, this patient requires more than what we can give. Guiding that patient, can you go to this office, because they will listen to you and maybe a solution will come. And so these are the things that we ought to be considering. Allow me to come to a close and to hand over back to Dr. Kalundu. Thank you.
Thank you. Thank you very much, Dr. Lydia Okutoi. That was very practical and real shared experiences. Before you pull down your slides, there's a slide that you shared on what examples of what we are monitoring. Could you please kindly go back to that slide and just leave it there on the screen? And I'd love, before we invite Mr. Thomas and Dr. Olga Nyamor to open up this panel session, I'd love all of us in the chat box kindly just share with us, either in the chat box or the Q&A, what are you monitoring in your facility? What are you monitoring in your organization? Is there something that you've started, you're doing? It might not be on this list, could be something different, but you're doing something about it. So kindly share so that we learn from each other. What are you monitoring? And then we'll be able to read through that and learn from each other. Thank you very much. You've mentioned quite a lot of things that are real issues. In one of the slides, Dr. Okutoi, you talked about involving leadership. You've talked about what that looks like, an hierarchical relationship, horizontal. You've talked about the important role of nursing, how all staff can be integrated to quality. You also give us a comparison of what other facilities out there globally are doing and how their organograms look like or their structures look like. And so I'll continue picking on that because we'd want to hear more about how we can make this be reflected or relatable. And as you said, learning systems, how we can bring that home in all our facilities. So thank you very much. Don't drop off, stay online because we'll still come back to you with many, many questions. Dr. Nyamor, Olga?
Yes, Dr. Kalundu.
Yes, how are you?
I am well.
Karibu sana, karibu sana.
Thank you so much.
Yeah, so maybe just focusing on that slide on the screen. I know in KU, it's a new facility. You've been there for some time. I'm sure there's some things that you've learned from this session, and there are things that we can learn also from you. So looking at the screen on the slide on the screen, what are you monitoring at KU TTRH?
All right, thank you so much for the question. I hope I'm audible.
Yes, you are.
All right, so first to begin, what you have displayed, out of what you are displaying, we are measuring hospital-acquired infections. We are also measuring our TAT at the A&D, OPD, specialized clinics. So TAT, we're really big on it. We also measure our mortality, and we go as far as doing case-specific mortality rates. We are currently working on, we do have morbidity and mortality reviews per department. We also have environmental swabbing under public health. So I'm just borrowing from your slide. I'm trying to look at what you're doing and seeing what we are doing as well. So we are currently doing a QI project on TMED, that is focusing on environmental swabbing. And then we do have departmental risk registers. I think we are trying to do what you're doing as well. So to answer your question, we do all of these things as well.
Thank you very much. And it's good to see that we are all reading from the same script. Mr. Thomas? Karibu sana.
Thank you, and good evening.
Fantastic. Good evening to you. There's somebody who asked, where can we get these documents? There some documents that were shared in one of the slides, the Health Worker Safety, National Health Worker Safety Policy document. There's also another document that was shared, and somebody is asking, as we just get onto it, where can we get these books?
Thank you. I think this is, as Dr. Okutoi mentioned, it's been a collaborative effort in terms of development of this. And this document can be found on the Ministry of Health website. You can share the address. We do have the national action policy, the national policy. There's an action plan for that, and there's a quality certification framework. You can get that from the ministry's website. The quality healthcare patient safety bill, of course, is continuing through review. We can get that from the parliamentary website. Yeah, thank you.
Thank you very much. And just before I let you go for now, there's a time I sat in one of a presentation that you were doing, and you're talking about Kenya Quality Model for Health. It is one of the standards that I can actually say was almost a national standard, became a national, not almost, it became a national standard. And I don't know, maybe you could tell us how far are we in having national standards with regards to quality of care? And is it something that we can bring back in case we've dropped the ball at some point? Is it something that we can bring back and have standards that are at a national level that can be adopted at facility level? And what would that take to have that journey getting on board again or on track again?
Yeah, thank you. Thank you. The KQMH standards are standards. Of course, they're our national standards developed. We are owned within government, and they have, of course, uptake has been widespread across all 47 counties. We've seen a lot of public facilities taking these up, and private facilities also doing that. Of course, the biggest challenge we've had with this is that with the national standards, them lacking, us lacking as a country, a mechanism where there is a formal MOH recognition for this. And so we've had people have different facilities, just going in and taking up international standards. But the effort that we have made is actually on the slide that is there, the development of the quality of the quality healthcare and patient safety bill. So in the bill, we state very clearly that we will have national standards that will be gazetted by the cabinet secretary. So, and those standards are the KQMH standards. So we're bringing them back with regulatory, like giving them a regulatory, like Ahmad really saying this is the backbone as a requirement for that. So as we implement quality and on issues of patient safety, KQMH is coming in there as a standard that that will be used for in terms of licensing, in terms of accreditation of facilities. So we're using this bill, which we really praying becomes a law, to be able to bring the standards back. And of importance to note is that accreditation now based on these and the SHA Act is really not voluntary, because for facilities to be able to be empaneled on SHA, they must be accredited. So using these Kenyan standards, which is KQMH. So we're really bringing them back to answer your question with a regulatory backbone for them to be able to be implemented across all facilities in the country. Thank you.
Okay, thank you very much. And you brought up the issue of accreditation, and we know accreditation sometimes require quite a lot of resources. It's resource intensive for the facilities that have already been able to implement it. What is the one advice that could give any facility leaders who are in this forum on where to start and how to start? This includes facilities that are lower level facilities and may not have the huge resources that most private facilities have, or even a private facility that is just starting up, or a clinic, outpatient clinic. We have quite a number of outpatient specialist clinics being round around. So what would be an advice that you'd give them as a starting point as the bill becomes law or continues to go through the parliamentary process to become a law? Where should they start?
Yeah, thank you. In the development of KQMH standards, and I'll try to answer it in this way, we have really drawn from experiences from other jurisdictions and really looking at lower level facilities, smaller facilities, larger facilities. So, and the thinking that is in here is that we'll develop a system where we can rate facilities, rate in terms of accreditation, do a rating for accreditation from star 1 all the way up to star 5. And that will make it easy for our facilities to begin small. So we would really encourage facilities to begin small. When you look at the KQMH standards, it's actually really talking about different aspects of healthcare delivery. And so we'd encourage facilities to begin small in terms of meeting these standards. And then knowing that in the law, and we'll put that very clearly, we have different star rating, different levels of compliance that we really would want to encourage. And we've seen these working in different jurisdictions, low income, for example, LMIC, countries. And this then will really encourage them to really begin small as you try and meet the standards going all the way up to 5 stars. So begin small, look at the standards and implement them. And really they are Kenyan standards. We've customized them, looking at scenarios that are there and looking at our situation. Yeah, thank you.
Thank you very much. So to all of us, all 484 of us, kindly let's look at the KQMH standards. If your facility has not started implementing or taking the journey towards accreditation, start with that. As Mr. Thomas says, it's a low-hanging fruit, and you can start implementing that as you continue building on to more advanced accreditation processes and standardization processes. Thank you, Thomas, for that. Dr. Octoy, I think we've given you a break and now you can be able to take a question. As somebody who's implemented quality programs in KNH for a couple of years and you've had robust experience in this, I'd want to ask, what is the one behavior or culture that you've encountered among healthcare workers that has made it difficult to implement these programs or to bring change when it comes to quality initiatives across the board?
Thank you, Doc. That is one of the things that are called a difficult question, but I'll take it in stride. So I think we have learned to shelve some ideas we'd want to implement when it seems like the time is not ready, because we truly appreciate that the frontline at times has limited time, and at times something is not just a priority. So I could flip the question and put it the other way. When did it become easy to do something?
Yes.
It became easy when there's alignment between what is being suggested and what the department thinks it needs. It's very difficult when you bring in something that the team does not think like it's necessary for them. And so as a quality improvement practitioner, in the spirit of system learning, you keep preparing, being ready for the time when people will be ready. Of course, there are times we have forced readiness using the stick. So there is what Thomas has said, the regulation. Once something is a regulatory, whatever requirement, it is a stick. People will make sure they'll do it. So at institutional level, how do you up the items you want to be on the table to become regulatory? At times we use getting into the appraisal system into performance contracting. If we think something is very important for a certain department, we talk to the senior director clinic. Of course, we interest the department, but then at the time of performance contracting, we ensure they take it up in terms of this will be, and the performance contract has a specific narrative that this will be the objective and this will be the activities. So it captures it very clearly, but we can see that will bring aspects of people complying. You may get minutes, you may get tick boxes that have been ticked or checked, yet the essence. So whenever there's alignment of people understanding the essence, why this matters, it's usually very easy. In fact, the department that called us, how to quality wako wapi, come we work on this. And yet it's something that we've been floating on. So we have learned to do our homework in listening to where the pain points for the institutions on matters quality and safety, and being ready to give advice, or at times to use the forcing function, because some items do not require a whole financial year for you to come and plan for an appraisal. They require immediate action. And so there is both what we are committed to do and what the situation requires us to do. And most of the time in KNH, we are working with the senior director clinical services or the director nursing services. This is their pain point. And so we help them. We become like the consultant science of improvement of patient safety at advice. And so we guide the institution at that point. And so when the culture is not open to especially see the pain point from the perspective of the system or from the perspective of the patient, because there are times some of these practices are very cumbersome or take more space, more energy, and so they're even expensive to the system. But there are times when it is clearly to the patient, and so that becomes our role. And so that part of we listen, we care is an ongoing concern that we continue listening. It's not you listened yesterday, today you listen to the patients and the needs that they require. And speaking of that, there's a question from Omondi about how we involve the patients for their responsibility. I think we've shared the patient charter. The patient charter clearly gives the patients responsibilities and their rights, and that is also captured in the document by MOH, the patient charter. We have a revised one. We have a new revised charter, which we are about to have it go out. It clearly gives the patients responsibilities, and then what are the patient's rights. And these are not documents just to be hanged on the wall, but to be lived. And so we've had opportunities to go around with staff and to go around with patients on whether they understand this, especially where there are ethical dilemmas. It becomes very clear. Are they looking for a second opinion? Did we communicate rightly? Because it's the patient's right for us to give them information for the care they are receiving. And so we engage the patient as such. And in the world now, in the quality and safety space, there's something called co-production, whereby it is always good to listen from both sides, because at times there is opaqueness at the level of senior leadership and the frontline not appreciating. So our new CEO quite walks around, and even our previous used to walk around, and our senior director clinical services does a lot of walking around. Same to the nursing director. So that walking around helps us when it comes to giving ideas. We are appreciating what the frontline is saying. This is their issue. Also, we are able to hear what the patient. So key to institution is what mechanisms are there for us to allow patients to both support design or the thinking of how to do things, and then the doing, and then get the feedback. This was how we felt at the end of it. So those are some of the things that the quality and patient safety programs should look to. How well are we listening to the patient? And since it is continuous, the patients keep coming in their complexities. Today you'll have one who doesn't understand Kiswahili. Tomorrow you'll have one who requires sign language. Another time you'll have one who has a child with a special need who needs to come to the hospital much more often and help on something because of the nature of their child. So I think it is, we can never exhaust it. We need to continue being at that place. Are we listening enough to the patient? And continue saying, are we being responsive to their needs? Yes, we're giving technical care that is right, but are we being responsive to their special needs? And could our not collaborating with the patient and the family be making us not get headwinds in our desired goal for their health? And so those are the things we continue being curious about. Thank you.
Thank you very much. And I like what you said about shelving ideas when the time is not yet ripe. That calls for a lot of wisdom when it comes to initiating quality programs. Dr. Olga, I just want to hear your perspective on what Dr. Kutoya has talked about, aligning what is being suggested with what the department or the clinical teams feel is necessary. How has your experience been at KUTTRH when it comes to aligning what you feel from the quality department that is what the direction we should take and what the clinical teams feel is necessary for them at that point in time? How has that been for you?
Thank you so much for the question. So fortunately for us, by the time we started, I had just attended a conference by Acquire, and I learned about co-production. So from that conference, the first thing I did is to involve the HODs, the heads of departments. So whenever we want to come up with a quality improvement project, whenever we want to measure any metrics, we go to the HODs, understand what their pain points are. For example, currently we're working on a look-alike, sound-alike QI project. I realized that when I come up with a project that I want to shove down their throats, let me use that for now, there's a lot of resistance. But in a separate department, we decided to start checking the SSIs because the surgeons were very curious to see what their outcomes are. And in that department, you find that the buy-in is much, much higher than the ones that I am coming up with. So to answer your question, I found that it is easier to co-produce, to involve the HODs and to work with them and to understand what their pain points are. And from there, we work together as long as they align. It's all about quality improvement at the end of the day. I hope I have answered your question.
Yes, you've answered. And actually, speaking from KNH perspective, that has been the same experience we've had, that it becomes easier to work with the direction that people are leaning towards and understanding from their perspective compared to pushing for your own indicators, metrics, and desires. So yes, thank you for that. Just before you go, Dr. Olga, how easy has it been to get the leadership? We've talked about getting the clinical teams on board and engaging in quality programs or initiatives that you're starting. But how easy has it been to get your leadership, your board of management to understand or to be engaged in anything that matters quality in KUTTRH?
Thank you for that. Fortunately for me, I would say it has been very easy. So we have a very supportive CEO. So when I joined the department, the first thing I did, I remember, was to prepare a board paper to get leadership buy-in from the main board. And during the presentation, the board was very keen. We want to achieve JCI accreditation. We want to achieve JCI by 2030. So it is part of the board's strategic plan. Therefore, it was easier to get support from the board and the CEO. Again, we are also ISO certified, so they understand what accreditation is all about. And there's a lot of support. So I will say it has been easy for me so far. There has been a lot of support from our leadership, including the Director of Clinical Services. And just to add, we have, what do I call it? We have a 3-year plan to achieve COSASA. So we have a structure, we have a roadmap. So, and this roadmap has been shared by our CEO, and she's passionate about quality. So I think to answer this, we have a CEO who's very supportive, and she's willing to allocate resources for quality. So that is my experience. Thank you.
Thank you very much. And from the last 1 hour and more, the things I've picked is that there has to be leadership support for any quality improvement or quality initiatives to run. I've also heard about engaging staff, whether they're frontline staff or they're the physicians, surgeons, anybody who's in that system, the clinical teams, engaging them in any quality initiatives that we are doing. And also just looking at indicators, what are we measuring? Dr. you hinted something about silo, working in silos when you're talking about having quality leadership being an hierarchical, having IPC. You mentioned something, IPC is for all. Patient safety is for all. Of course, quality improvement is for all. Patient centeredness is for all. How do you reduce silo working between the departments and this ensure that we are all speaking from the same script? I like that what Olga has brought up about having a vision, a strategic plan, a 3-year plan, a roadmap. Those are the words she's used. So apart from having these beautiful documents, and that also includes the current quality care and patient safety bill that's in Parliament, how can we ensure that when we come to the ground, when we come to these facilities, we are all speaking the same language, we are all working together towards a greater good, and we are not having competitions, or we are not having that is for quality assurance, and that is for patient-centeredness, that is for patient safety, that is for anesthesia, that is for pediatrics. How do we ensure that? How can institutions ensure that they are working together to reduce silo working?
Thank you for that great question. I think I'll start from where Olga stopped about their journey for self-care and then going towards JCI. A quality management system in itself helps the institution to think as a unit. So KNH is ISO certified 9001 2015, and the current CEO has a vision, and we already have a team of transiting to the first ISO standard for health, that is ISO 7101 2023, which the hospital has embarked on the journey, and KEBS ready to start that work. So the QMS by itself, in you knowing that you win as a team, as a whole, is one of the things that brings people together. It may be artificial, but it is real. It is having that third party attestation that you've met these standards makes all of you do something in a certain one direction. But one of the practical aspects that helps to reduce silos is leadership. Actually, it's around culture. And so the clinical leads and those in their respective departments enable us to think as one and as a whole. And the institutions have those opportunities of monitoring the hurdles that people have by the bedside. But in governance, it is those meetings that happen weekly. For example, in KNH, we have the Clinical Leadership Council that happens weekly. So when people are saying, in my department, I don't have beds, in my department, people are waiting for this long. It is not an ICT problem, it is not a nursing problem, it is not an A&E, it is all our problem. And so when we are brought together by leadership and taking the accountability for what we should be doing, then that in itself reduces the silos. That in itself reduces the silos because you're trying to work towards one common good. And then also just the ethos or the mission, why you exist, to do what. It can't be that I am okay, I'm doing well in finance, and yet this patient cannot clear it fast enough to go home and think that the care that was given in theater, someone will not remember that it was good quality because I've stayed for very long, because the system is down, because of ICT. So I think one way of reducing silo is having that culture of being responsive to the patient. When we say that we are responsive, then it means we are caring about the patient journey. We are not looking at my individual contribution. And that's why when you do the customer experience or the customer journey mapping, we address what are the non-value add steps in that customer journey. And so we reduce silo by seeing and identifying the things that are non-value add steps and removing those redundancies. And we have the audacity in the Monday meeting or in the Thursday meeting to say, this is the pain point of the patient. So it won't matter whether the problem is from a different unit. That unit will have to come in to give an account of what help do they need. The rest of us being ready to help. And so by and large, it is a leadership, it is an organizational construct, but it is the leaders can help that reduce. And we've seen that reduce when people are able to talk more, to take a phone call, to walk the patient to wherever they're supposed to, and to have some dedicated staff who can help that coordination and be like the thermometer of how the patients are experiencing this care, that they're not having some places with not satisfaction or non-value add steps, and then other places they think it is okay. The total journey map of the patient will be that this part, I got disappointed. And so silos reduction is about identifying it and addressing it at leadership level, where there's no permission that the CEO is asking from anyone to change of clinical director. They will give now a directive. How do we help you do this by this time? Yeah, I think that is from the aspect of what is currently happening at KNH. And when there are changes, when there are transformation, the more people talk, the more now we appreciate the silo mentality that needs to be addressed. So convening for those conversations and reviewing and hearing our customer experience. Thank you.
Thank you very much, and thank you for that comprehensive answer. And I think these are practical measures or steps that we can take. And one thing I hear very loudly, communicate, communicate, communicate. Communication is what can reduce our silo ways of working. If you have a heavily siloed system in your facility, I think some of the measures that have been shared can be very practically applied in your institution. Thomas, the Quality Healthcare and Patient Safety Bill 2025 is very vocal about patients and patient rights and their safety. And there's a question from Innocent Kadu, and Innocent is asking, how can we measure the involvement of family and friends in ensuring there's quality and safety in hospitals and beyond hospitals? And the second question is asking, how do we handle individual medical staff negative attitude with regards to offering quality, safe patient care? So what are some of the things that are inside that act, that bill, that you can highlight when it comes to patients' rights and when it comes to raising a concern or a complaint, and that are enshrined in this particular bill, so that at least we can all learn from what is coming and what we can start doing?
Yeah, thank you. Thank you for that. Maybe I would really like bring out what the bill brings out on the area of patients' rights and safe care. One of the things that we have done is to enshrine the rights for every patient in terms of receiving care. We're looking at issues of, the facility, prescribing standards in terms of sanitation, lighting, and ventilation, and even up to nutrition. So the bill enshrines that in terms of looking at that. Then for the patients, and this is important, and just looking at what KNH is doing and KULTH is doing, the bill builds a mechanism for reporting for development of reporting systems. So, for example, adverse events and linking facility performance indicators. For example, what you see, the issue of waiting times, outcomes, patient satisfaction. And so the bill requires that. So for facilities to develop a mechanism for that and linking this with the national digital system that we're doing. So the facilities are required to have mechanisms for that in terms of looking some of the metrics that they will be able to monitor. In terms of safeguarding the rights of patients. We have, this is bringing in a tribunal, a dedicated healthcare tribunal, so for the sector. And of course, looking at issues, giving patients an avenue for them to be able to, if there are disputes, if there are complaints about the care that they have received. So this provides that. And this tribunal can initiate cases by itself or has an appellate, like cases that have been issues that have been where dispute resolution mechanisms have failed at the lower levels. Then it forms an appeal mechanism for that. And the other very important thing in terms of this is looking at this is, of course, this performance data, linking it to the national health data infrastructure. And the bill really is not just, and I know that's a question that should ask. It is really looking at embedding safety and quality into our governance. Really, like for example, in terms of quality improvement structures, we really have developing a harmonized quality improvement structure, going up from the national level. At the national level, we're developing a framework. We're really coming down to the facility, and what we've seen in KNH, a program for that. So putting those in terms of governance structure, the bill requires that, puts requirements for that, for facilities to be able to do that. And then very clear, very clear, clearly states how to delineate the patient rights very clearly, the right to be heard, the right to care, all that very, very clearly in the Act. Thank you.
Very much. Thank you very much, Innocent. I hope we've gotten your question answered. And if we're not doing it already right now, then a system is coming that will regulate how we do it. And so when it comes to a question about handling individual medical staff negative attitudes, now the patients will have the opportunity to directly report to a tribunal in the event you don't have a feedback management system in your institution. And even if you have, the bill allows them to go over and beyond that system and report at a higher level. And so it's part of what we need to start working on and implementing. How do we ensure that we are actively encouraging our patients, our families, the families of these patients, to give us feedback to improve our systems before the regulation catches up with us. And so thank you very much for highlighting that, Thomas. We truly appreciate that. Dr. Toy, there's a very tough question here from Lillian Okol. And she's saying, I'll read the second part, but we'll still go back to the first part a bit later. KNH has had bad experience with patient safety despite very good quality and safety structure. What could be the weak link? Dr.
Great. So just to start by giving a disclaimer that healthcare is provided in a very complex interaction between various players, and even the complexity both of how care is provided, but then also of how the kind of patients that could come makes it to be error prone. It is said that the burden of harm is maybe higher than the deaths we get from HIV in terms of numbers, and then also the financial implication of the same. So KNH is like any other health system. However, it has its strengths and then it is challenges. One of the roles that I mentioned at the beginning is to be able to have a learning health system. A learning health system reflects on its outcome and it tries to preempt. There are times we have done very well. There are times we have had our challenges. one of my roles, or what my boss appraises me for, is how often am I able to pick the things that are, what are they called, the near misses, for the purpose of preventing anything wrong to happen. And for that, as a hospital, we have a learning and reporting system, an incident reporting system. It is anonymous. And we also have the one for the mandatory, what we call the sentinel events reporting. And so I cannot underestimate, or rather lower the harm or pain that a family can encounter. But believe you me that we continue to learn. And for some of the items that you may think are obvious when you go to investigate, you find the factors that were around them are factors that we can do something about, while the various other variables that keep changing. And so we keep learning, giving recommendations, but we continue being a place where we get the referral at times, the last of call. We continue being in the same environment of the unknown African person will likely come to us, and having also that, what we call like more than 5,000 healthcare workers, to be able to coordinate all that and to have things aligned. So just going back to what we call the Swiss cheese model, that what is this last thing that makes harm reach the patient, and what can we do about it? So for each of those incidents, at times we tend to know more about them than maybe the new person who is coming, or the one who was not there on duty. And so as a hospital, we try to have patient safety to be institutionalized across all the departments, and each department develops what they call their own sentinel events, and they do their own risk register and discussions within the departments. So I'm not trying like to cover, but I'm trying to put system-wide things that could make it different and could make the new intern who's joining in, or the new staff who's coming in, to know that in this department, this is what we track, and this is what hit us yesterday. And so having those conversations requires both at the department level to have a vibrant discussion. And so that keeps happening. Will an error not happen tomorrow? To the best of what we can learn today, we try to ensure that we have the resources and what is required. But from my patient safety principles, I require that the people at the front line are able to innovate, are able to adjust, because the circumstances are not the same. Today, they will have 10 people in casualty. Tomorrow, they can have 30 because Nairobi County is on strike, and maybe they have the same resources. So our learning is, how do we adjust to all those? And I think we take it in stride and learn forward. Today, we've been in a team that were discussing on learning from errors. And so how do we fail forward in that today's failure will not happen tomorrow? Yeah. And so that is my core question, as we adjust both on the information about what happened and on the preparedness and risk mitigation when the circumstances change. Because in healthcare, at times that patient who is there would look stable now, but in another few moments, they're unstable. So what does that need in terms of monitoring? How do we use the new skills and the innovation? Just today, we had somebody come to KNH, is it yesterday, and brought pediatric monitors that are able to have like 10 or 30 children all to come to one screen. So such things will be applicable to KNH, because at times we have acute patients, like 15 babies in one acute room. That doesn't happen in many other places. As far as a hospital, we endeavor to use technology, up the skills of our people, but at the same time, learn from the errors. By the way, many other hospitals, you don't hear about their things, not because they don't happen, because simply because they don't have the audacity to learn, to talk about it. Not to learn, but to talk about it. But in KNH, our nature is we are a public hospital. We have to inform policy. And so when we fail forward, but we try to mitigate. We have a robust risk mitigation mechanism that hasn't been put to address our more than 100,000 patients that pass through our institution in a year. I've said so many words, not to be verbose, but Dr. Kalondo, you do this role with me. How can you answer that question? Can you add more emphasis to what your boss has said?
Thank you,
Let's
Lillian,
let's share this glory.
Yes, thank you, Lillian, for that question. And sometimes it's very good to have such real questions. I mean, after a presentation about the structures that have been put, what we've learned, how we've grown, it's good to have a very sobering question in there. So thank you very much, Lillian, for this question. And just to, what I would say is the same thing Dr. Kutoya said. Yes, we acknowledge bad experiences happen in healthcare across everywhere. Even when you go to NHS, which has a very good system, it has a whole investigation body. Bad experiences happen with regards to patient safety. When you go to Birmingham Women's Hospital, that happens. When you go to any facility, even John Hopkins itself, these patient safety experiences happen. So what can you do, or what can you learn from KNH at the end of this day, or in the next, before 10 minutes are over, we're almost winding up, is one, develop an incident reporting system in your facility. Start from there. It doesn't have to be an online one. You could start with a paper-based one. So we've graduated to an area where now we are able to incorporate online reporting to make it easier and more anonymous. Kindly make it anonymous so that more people are free and able to tell you what they see, what they hear, what they experience when you're not there. If it becomes, if it's not anonymous, there might be a lot of fear of reporting because you can easily trace it back to me. It's Kalondo reported, and so you can come back and say you reported this. And people get a lot of cold feet when that happens. Number two, learn from any incident, no matter how small it is. Don't wait to learn from the big ones. Start learning from that small one, where there's a wrong dose administered, where there's a wrong prescription given, where there was a documentation missing, the file was missing, where there was a patient did not have patient identification, even a simple bracelet was missing. Start learning from that. Don't wait for the big ones to learn from them, and start putting measures in place. When you identify a pattern, when you identify trends, look at your data, because that's how you'll pick the trends and identify patterns. And that will be able to tell you when we get new teams coming in, we experience a lot more near misses, we experience a lot more adverse events. And so something has to be done from the entry point to mitigate that. So please learn from KNH. You're welcome to come and learn from us. We are as open as you've seen Dr. Okto's presentation is, and pick something. Pick something from our experiences, pick something from any facility that you've seen in the media with a negative experience. Go and learn from them. Pick what you can improve or what you can put in place in your facility to ensure that this does not happen and it's not replicated. The worst thing we can do is see experiences on the TV or on the media and fail to pick a lesson from it, and it happens under our watch. So my encouragement to you, please come and learn from us. Come and learn from any other facility that you've seen, whether it's Aga Khan, whether it's Mater Hospital, whether it's a private facility that has been on the media. Go and learn from them and pick the lessons from there. And I'm sure if you continue joining more forums where patient safety is being discussed, where quality is being discussed, you'll pick a lot more that happen that are kept under the covers. And let's not keep these things under the covers. Let us talk about it. And it's only from talking, it's only from sharing that we're able to improve quality of care across across Kenya and also the continent. Thank you. Thank you very much. Thank you, Dr. Kutoi. Thank you, Mr. Thomas Gashuki. We truly appreciate your wisdom every time you're talking about the Quality Healthcare Bill and Patient Safety Bill 2025. We learn so much from it. And I'm excited to hear that KQMH is still coming back and we can start small by having national standards that we can all implement. Thank you, Dr. Olga Nyamor. We've learned quite a lot from you. I can't say that you're now starting. I can say you've started and you're moving. And I'm excited to hear that you have a roadmap that you're working towards. So to any facility that has joined us, my urge to you, have a roadmap. That's the one thing you can borrow from KU. Have a roadmap. Have leadership support from the beginning, from the start. Have leadership support. Get your leadership to be part of it, to move with you, to give you all the support that you need as you start. From Thomas Gashoki, he's told us about having quality metrics. Start measuring something, start implementing something. And that just requires you to go back to the standards that exist. Go to KQMH standards, read through it. He shared a link in the chat in the Q&A section. Go through those standards and see, what can I start? What do they say about an accident and emergency department? What do they say about the wards or the theaters? What should I have there? And start implementing, start measuring, start finding opportunities for improvement. Engage your frontline staff, engage all staff in any quality initiative that you're undertaking. And then work on silo mentality. Make sure that it's something that you proactively work on. It might be a culture issue, but you're able to work on it, start working on it, and starting to say, how do we work together with all these teams? How do we communicate better? And then prioritize quality programs, quality initiatives in your facility. Make sure you're prioritizing them. They are not an afterthought, but they're something that we're proactively putting at the forefront, whether it is in our performance contract, whether it is in our targets that we're setting for each other, whether it is in our vision for the facility or any other measures that we're taking. Allow me to hand over to Caroline Kendi, who can take us through what is currently on our screen, and as she wraps up this session. Thank you.
Thank you so much, Dr. Kalondu. Thank you so much for the informative discussion we've had. My name is Caroline Kendi. I work at Halisi Family Hospital as a quality and patient safety manager. I serve in the Society for Quality Healthcare Kenya Research and Conference Committee. And I'd like to invite all of us to attend our first annual scientific conference that is going to take place in November 28th at Pride Inn Aza at Westlands. And our theme is start where you are, build with what you have, quality and safe healthcare for all. So the question is, how do we start where we are? How do we bring everyone on board from lower level facilities all the way to higher level institutions? So during our, we're going to be having pre-conference webinars like what you've done today to discuss more. And during our conference, we're going to talk more about leadership, buy-in. We're going to have more conversations around accreditation, around sharing our success stories so that no one is left behind, so that even in resource strength and in a dispensary, everyone is able to provide quality and safe care for all our patients. So we are also calling for abstracts and posters for the different quality improvement projects you're doing at your facilities. I loved the question that we were asked earlier about what are you measuring. So in the different projects you're doing in your institution, kindly share with us your posters and abstracts so that we can all learn together to ensure that quality and safety is achieved. Thank you very much, Dr. Kalondu.
Okay, thank you very much, Caroline. Final question that we're going to answer as we say goodbye. Jackson, how can you come and learn from KNH? Kindly write to the CEO. When you go to the KNH website, you will find the email address there. Kindly write and request, and the door will be opened. It's always as simple as just asking to the management, and that will happen. So please, Jackson from Isinya, please come. We welcome you to come and learn and to come and start seeing how you can start if you've not started, where you can start if you've not started. And also maybe you could join the conference and also learn what are other facilities doing, where they started, whether they had money or didn't have money, where did they start? So Jackson, karibu sana, tunakukaribisha Kenyatta na tutafurahia kukuwa na wewe kusoma pamoja. Thank you very much. Do have a good night. And thank you very much, Dr. Lydia Okutoi, Mr. Thomas Gashuki, Dr. Olga Nyamor. Thank you very much for sharing your experience and your journeys towards developing quality and safety programs in your institutions. Asanteni. And thank you, KNH research team, for this forum. We truly appreciate you, and we are grateful for the opportunity that you've given us. Good night and have a blessed evening. Bye.
Thank you.